Hello, everybody. Olá a todos os amigos de LASPGHAN. Acá estamos novamente para mais uma atividade nessa intercâmbio de NASPGHAN com LASPGHAN. Hoje teremos uma apresentação extremamente importante que tem motivado grandes dores de cabeça quando a gente está diante dessas situações. Vou passar para a Han Vo, que vai apresentar o nosso speaker. Han.
Thank you, Dr. Sulitoro, for the introduction, and good evening, everyone. Welcome you all again to the second webinar of the NASPGHAN Visits LASPGHAN webinar series. Tonight, we look forward to listening to Dr. Maire Conrad from Children's Hospital of Philadelphia. She will talk about very early onset inflammatory bowel disease, and we hope you will enjoy this webinar. Thank you, Dr. Conrad.
Hello, I'm very grateful to be here today to speak to all of you about very early onset inflammatory bowel disease. And I'm going to review, first, I have no disclosures, and I'm going to first review how to distinguish very early onset IBD from older pediatric onset IBD. I'd also like to discuss the evaluation of a child that you suspect to have very early onset IBD, and then I'll review a couple of patient cases to demonstrate our evaluation and diagnosis. So there's been multiple studies around the world that have demonstrated a rise in the incidence of inflammatory bowel disease in children. In particular, the epidemiologic studies from Canada have broken this down among age ranges, and the fastest rate of rise has been noted to be in a Canadian study of children under the age of 5 who are increasing at a rate of 7% per year. And this is particularly important, I think, as we start to understand what are the pathogenic factors that lead to very early onset IBD and what distinguish it from older onset IBD. So the rise of IBD we know is multifactorial, and while there are many environmental factors that are contributory, the genetic influence of this disease continues to be explored and understood. Initially, genome-wide association studies were used to shed light on the common variants that are associated with IBD risk. And these studies have been performed in adults and mostly in older pediatric onset children with older pediatric onset IBD. The loci and subsequently the genes identified in these studies have been include many parts of the host microbe interaction that are involved and have provided targets for many of our established therapies, our biologics, and as well as the new small molecule medications and the future medications that are in the pipeline for development. Much emphasis on the change in the epidemiology over the past several decades has been attributed to the westernized diet and the effects of the intestinal microbiome. The microbiome is rapidly developing in the first 3 years of life. There are many predetermined and variable factors that influence this, from genetics to birth root geography, hygiene, stress. Over time, all of these things can influence the microbiome. In children, disruption to the microbiome during the early years of life, in this birth to 3 years, can really set the stage for developing the immune system as well as the microbiome's stability. And this is a key window of time when disrupting the microbiome may have lasting effects on the immune system that could be in the short term or long term of life. And I think this is a particularly interesting area of study because of the major implications that could happen that may lead to why we see more very early onset IBD than ever before. Very early onset IBD is typically diagnosed in children who have symptoms before the age of 6. And we think about this in different onset because of the diagnosis early in life, which could be the neonatal period or the first month of life, the infantile period, first year of life, or in the early childhood onset from 2 to 6 years old. It's a heterogeneous population, and there can be a range from mild to severe disease. And it differs tremendously from older onset pediatric IBD. And so I really implore you to think outside the box of just Crohn's disease or ulcerative colitis. These children have a spectrum of disease. They really don't follow the mold of the typical diagnosis patterns and really need to be considered in their own category of IBD. And this is likely because there are different drivers for this disease. It's not just the typical risk factors that you have with older onset IBD or adult onset IBD, but it really is unique in of itself. So to start with, what is the differential for very early onset IBD? So you may see a child who has diarrhea, poor weight gain, and your index of suspicion does really have to be quite high to suspect VEO because it's rare, but it should not be missed. So of course, most babies with failure to thrive, severe reflux or vomiting, watery stools, blood-streaked stools do not have this condition, but it should be on your radar. The differential can really range from infectious to milk protein allergy, FPIEs, and also ischemic conditions. Fistula and ano is an entity that often goes in the United States to be referred to general surgery for care, but some of these patients have a more complex fistula and should not be just considered to be a one-time infant event. And I think it really requires a referral then from surgery to GI when to consider if there's something more underlying going on there. Immune dysregulation and primary immune deficiencies can present in a multitude of ways. They shouldn't just be considered in children who have recurrent infections, but now the ultimate presentation of immune dysregulation might be very early onset IBD. And so having an index of suspicion for these underlying etiologies leading to the IBD is really important because it will guide therapy and other considerations for choosing the medications. Of course, celiac disease and Meckel's diverticulum are also other conditions that need to be considered along with VEO IBD in these children. The major signs to look out for in a child you're evaluating for very early onset IBD, first and foremost is growth. Of course, in pediatrics, this is something that we keep very high on the list of things to look out for. Many times we see children with VEO IBD who've had short stature or stunting, despite the fact that they have been given excellent calories or that their weight is on the chart and following the curve. We also see children who've been sick for some time or have had malnutrition, and that has resulted in delayed milestones. So asking questions about their development is also very important in the infants and young toddlers. Feeding difficulties, changing multiple formulas, having struggles with concerns about tolerance of formulas. These are things that we ask a lot of questions about. And if parents are changing the formula because of blood in the stool or concern for milk or other allergy, and there's still really no improvement or very short-term improvement, then further consideration should be given to an underlying inflammation and not just an allergic condition. Systemic symptoms that may also raise concern is fevers, includes rash, including severe diaper rash, can also include cradle cap, folliculitis, joint involvement, arthritis, of course, mouth ulcers that are, especially those that are either deep or recurrent, children who have been hospitalized for a diarrheal illness that's prolonged or atypical, and then any child who is ultimately getting an immunology consult or workup should be considered about who has diarrhea. What are the links potential between an immunology evaluation and the underlying cause of their diarrhea? So in our work at CHOP, we have looked closely at what makes VEO IBD stand out from pediatric IBD. And part of recognizing VEO IBD is to recognize that it's not going to look like your typical older onset IBD. So first of all, we have found that most children with VEO IBD have colonic-only disease, and some have ileocolonic disease. There's also a considerable number of patients that have panenteric disease, meaning that they have inflammation from the esophagus all the way to the colon. I think this is important because, again, it goes back to the fact that all colonic disease cannot always be discerned Crohn's disease from ulcerative colitis, and that there probably is an entity that spans both conditions that really is a child who's early in the development of their inflammation who's going to have this disease for a long time. Another key feature that we pay attention to is that the pathology can be confusing and it may not have all the typical features. You might not find the chronicity or the architectural distortion that is the key to calling chronicity to make the diagnosis of IBD. You may have a lot of active inflammation. There also potentially is a very strong lymphocytic infiltrate, may or may not have crypt distortion. And granulomas, of course, they help clue us into a diagnosis sooner, but are not always a sure bet to be in the VEO IBD population. Other clues that we find are biopsies that show just abundant apoptosis without other signs of inflammation. There can be some epithelial injury associated with the apoptosis or just the apoptosis alone. Sometimes our pathologists will say things like, this looks a lot like graft versus host disease, but of course this patient hasn't had a transplant or other reason to have such a condition. But the findings can have an overlooking a similar presentation. In the duodenum, you may see severe villus atrophy or villus blunting with a strong lymphocytic infiltration without other signs of celiac disease. This also should be a clue to think about very early onset IBD. And finally, eosinophilia. So we have seen eosinophilia, sheets of eosinophils from the epithelium through the lamina propria to deep in the crypts. There's also can be mucosal ulceration with eosinophils. This is a common finding in pathology that we debate often with our colleagues who focus strongly on eosinophilic disorders, because the question is always, is this IBD or some allergic type process? And I think one of the biggest discerning factors is what the visual looks like and what the endoscopic appearance is to help discern what is more likely to be a milk protein intolerance or allergy versus a progressive IBD-like picture. So it's important that while we talk often about very early onset IBD as being a refractory and severe condition, there are many patients who can be induced into remission and maintain a quiescent disease course. And there are many patients who do really well on nutritional therapies, whether it's diet therapy or exclusive enteral nutrition therapy. And in a child that may have a feeding aversion or have been mostly formula dependent, this can be a really great way to try to get their disease under control with the help of a dietitian. 5-ASA is also used, or sometimes long-term antibiotics can be used to control the bacteria that then can control the inflammation. And then, of course, we think about the use of anti-TNF and other biologics for treating the very early onset IBD. So we know from studies that were done first by Dr. Kelson here at CHOP back in 2014, in this graph on the left, that the rates of response to Remicade or infliximab and the rates of maintaining patients who are still on it at 1 or 2 years are quite low in the younger age group versus older. And in that study, she compared the rates of response as well as the maintenance of therapy to the rates that were reported in the REACH study, which were the original clinical trial of infliximab in inflammatory bowel disease for older children. And the REACH study was quite impressive with its rates of response and maintenance at 1 to 2 years. And our rates that we saw initially when children were dosed at the typical 5 per kilo dose were quite poor. And then again, when we had a larger cohort of patients, we were able to look at our rates of failure to infliximab and to all anti-TNF therapies over the years. And again, the very early onset group had a much higher rate of failure to infliximab and all anti-TNF therapies than older onset IBD. So in both cases, the use of infliximab was well before many of our therapeutic drug monitoring techniques and standards have come into play. But this was with typically standard dosing. And even without, we see that many patients don't have a robust response to the anti-TNF without a lot of medication or very frequent medication. So what we have learned from these studies and our experience is that really all very early onset patients need to be considered for higher infliximab dosing. Dosing 5 milligrams per kilogram in a very small child with a high inflammatory burden, especially if they're quite anemic or hypoalbuminemic, it does not seem to be as effective as when you can try to give higher dosing of the medications. We found amongst our patients that 2/3 of them, when done, when induced with infliximab, had very low or undetectable levels for the week 10 to 14 dose, well, that's a much less common issue amongst older children. And so we often use an intensified regimen in order to obtain therapeutic levels and try to maintain response to the drug or induce response to the medication. So adjusting the induction regimen and then adjusting the dose and interval can often be necessary to gain the appropriate response. Some children really need every 2 weeks dosing, high dosing, in order to get response and to maintain it and not to drop the level to be subtherapeutic and lead to infusion reaction. Additionally, the VITO KID study that recently came out, which is a multi-center study that showed that those children with no prior biologic exposure were associated with the highest rates of response. But in particular, the children who were less than 30 kilograms at week 6, if they had a high trough, it was associated with remission. And most of the time, to get such a high trough, like greater than 25, they require 10 milligram per kilogram dosing to be that effective. So again, biologic medications, I think it's not unheard of and has been considered more about what's the appropriate weight-based dosing, and is it weight-based dosing actually appropriate for these small children who have a high burden of disease. But I think as our experience has shown over time, higher doses can have a more effective result. So similar to our experience that the distribution of disease is quite different in very early onset IBD versus older onset IBD, the rates of surgery and the types of surgery are quite different between the groups. So starting on the right, you will see that while the older onset children typically have ileocecal disease or ileocolonic disease, they also have more commonly an ileocecectomy. Meanwhile, on the left and in the middle, children who have colonic predominant disease are either going to have a diverting ileostomy without colectomy or ultimately have colectomy more frequently than the older onset children. And I think this really, like I said before, just demonstrates that the distribution of the disease, the burden of colitis is quite different in VEO IBD versus older IBD, as well as the response to therapy is quite different in VEO IBD versus older IBD, which leads to more necessary surgeries. So I spoke to the fact that the reasonings for many of these phenotypic and clinical differences among the very early onset IBD group and the pediatric IBD group is likely due to the difference in genetics and other factors that go into the onset of disease. So older onset children, the differences are probably more on a spectrum. That GWAS has helped us find those polygenic common variants that are known risk-associated genes, but they're not very penetrant. And so they're very common, but they're not penetrant. And the environment probably has a major role in the onset of the disease. Meanwhile, very early onset IBD uses a different approach, typically whole exome sequencing, trying to identify single genes, rare genes that are highly penetrant that result in the entire inflammatory bowel disease. But we know that this disease is increasing at a very fast rate, and it's definitely faster than what genetics alone can explain. And so therefore, there's an environmental piece likely involved in VEO IBD as well. So there has been a huge increase in discoveries over time in both inborn errors of immunity or primary immune deficiencies that present with an IBD-like picture, as well as what genetic testing has been able to help us find of IBD-specific monogenic defects. So what began as these important genetic discoveries to identify IEIs, which are the ones listed in green over this timeline, has evolved into an increasing number of IEIs with IBD, and then the additions in yellow of novel genetic causes of IBD themselves. These are the monogenic defects in VEO IBD that we have identified in CHOP. The ones that are in purple are the ones that we've successfully gone on to bone marrow transplant, because as a primary immune deficiency, a hematopoietic stem cell transplant can be curative for these conditions. So how do we identify these genetic defects? So we have put together a targeted sequencing panel of 98 genes that look specifically for genes we know that are associated with IBD and IEIs that are associated with IBD. If we find a pathogenic variant, a known variant that can cause disease, we will validate it and then plan an intervention for that. If it's negative, we are able, through our research study, go on to use whole exome sequencing. And that helps us to expand our search beyond the 98 genes that are known. Can we find other genes that are related to the immune system or related to epithelial dysfunction that can explain what's going on with this patient? And if we find a pathogenic variant that is rare, that is not available in the typical databases, that is not inherited from an unaffected parent, then we're able to go on with functional studies to try to show that this could result in the outcome of IBD. And these can include doing animal models, enteroids, cell models, as well as transcriptomics. And then finally, when WES is negative or when their index of suspicion is really high, we may go on to whole genome sequencing to further expand our search for genetic causes for very early onset IBD. This approach is taken, I think, both on a clinical and a research level. There are many clinical panels available now, and of course, there are ways to perform clinical whole exome sequencing to identify, to find a unifying diagnosis, especially in the youngest patients. Much work has gone into understanding how do we pick out the monogenic from the non-monogenic patients, the patients that are going to find a diagnosis in the genetics versus those who are not. And there were two recent studies, one from CHOP and one from Boston Children's, that looked at the monogenic children compared to the ones who have not had a diagnosis made by genetic testing thus far. And at CHOP, there were 41 out of our 650 patients. 47 patients had onset as infants, and the majority of them were the ones that were found to have a monogenic disease. We found that monogenic diagnoses were associated with significantly worse growth. So these patients were considerably growth stunted and underweight. And we also looked at the different immune testing that we routinely did. And while lymphocyte subsets are part of our standard screening to sort out what's going on with the immune system, they were not the best way to identify monogenic disease. But a DHR, which can identify chronic granulomatous disease, was quite sensitive for detecting CGD. So just furthering that the DHR really can be a useful study or a neutrophil oxidative burst to identifying patients who may have chronic granulomatous disease. And then in the Boston study, they also had 17 patients with a monogenic defect. 41 of those of 216 were infantile onset, and about 41% of the monogenics were diagnosed as infants. They saw higher frequencies of stricturing and penetrating disease amongst their VEO-IBDs in these young monogenic patients than they did in the rest of the patients. And I think that, that is a true statement where, as I said before, most patients have a colonic inflammatory type presentation. Stricturing or penetrating disease at a very young age, first year of life, should raise a concern for monogenic disease. They were more likely to have extraintestinal manifestations, more hospitalizations, and a much higher need for supplemental TPN, G-tube, and also that growth stunting was prominent in these patients. So I'm going to take a stand now to review a few patient cases and examples of where genetic testing was really informative and important and useful in sort of coming up with a treatment plan for our patients. So the first case includes a 6-year-old girl who has no past medical history. Her weight gain slowed around the age of 4 to 5. So before that, she really seemed to be totally normally developing, gaining weight and age appropriate. At age 6, she presented to her pediatrician with a labial abscess. And then a few months after that, she had diarrhea, abdominal pain. She was found to have a urinalysis that had bacteria present and leukocyte esterase concerning for a UTI. And so she was treated for a UTI. And then she was hospitalized about 6 months after that for again having a E. coli UTI. Her weight had continued to be poor. She still had symptoms after antibiotics and was complaining of left-sided hip pain and leg pain. She had elevated white count. She was anemic and quite impressive inflammatory markers. At that time, she was hospitalized with an ileostomus abscess. She had imaging that was concerning for wall thickening from the rectum to the transverse colon. She needed drainage and IV antibiotics of the abscess and required TPN for a prolonged period. She had an MRI that also, aside from the intra-abdominal abscess, noted a fistula at 6 o'clock along the left luteal fold that then persisted to her left labia majora. So this was intra-abdominal fistulizing disease as well as perianal disease. With the concern that this was Crohn's disease, she underwent an EGD and flexible sigmoidoscopy. They noted the perianal fistula. She had an ulcerated sigmoid, and her path was diagnostic with a crypt abscess and mild crypt architectural distortion. She was treated with Remicade and required higher dosing, 12.5 milligrams per kilogram, for about 6 months. She seemed to have reasonable levels from 11 to 16, but continued to have abnormal labs, elevated inflammatory markers, and some hypoalbuminemia. She was having loose stools, and there seemed to be some response to Remicade because she was worse off right before she was due. At that time, due to her imperfect response and having tried to maximize her Remicade, she was then referred to the very early onset IBD clinic at CHOP, where I met her. She was severely malnourished. She had growth failure. She was way below the growth curve for her age when she underwent an immune evaluation. And at that time, she had a DHR, which demonstrated an absent neutrophil oxidative burst, which highly raised our concern in this female for chronic granulomatous disease. She ultimately had genetic testing that confirmed an NCF1 homozygous, but with the concern of the abnormal DHR at that time, we were sure that she needed to stop Remicade. Remicade is contraindicated for patients with chronic granulomatous disease, so that's why it's so important to do this before when you have a patient that's presenting with an atypical and severe or refractory course. So she ultimately was referred for bone marrow transplant, but due to the significance of her intra-abdominal abscess and the fistulizing disease, she needed a diverting ileostomy so that we could slow down the reaccumulation of the abscess in her belly. She had required another drainage by interventional radiology, and she did quite well with a diverting ileostomy. She was able to undergo a stem cell transplant about 4 months ago, and we're now working on plans to reconnect her hopefully this summer. So I think the conclusion from here is just the importance of the genetic testing, the importance of the immune screening, the consideration of these conditions. You know, chronic granulomatous disease is the most common immunodeficiency associated with the presentation of Crohn's-like illness. And so having an index of suspicion for patients who have an atypical presentation or other ineffective response really, should be made sure that these kinds of evaluations by an immunologist or another or similar colleague could be helpful in choosing the right therapy and making sure you're not missing some other diagnosis that's really masking the true diagnosis. In case 2, this is a 1-week-old baby boy who presented to an outside hospital ER. He was full term, had a normal newborn screen, but presented with this abnormal respiratory pattern and had had a history of loose stools since birth. He was found to be acidotic with a bicarb of 16, and he was rehydrated and discharged because he passed a PO challenge. But he subsequently had several more ER visits and hospitalizations. He had emesis and diarrhea, was often lethargic. There were times he was hypothermic. He had repeat episodes of dehydration with the metabolic acidosis and was noted to have infections, adenovirus, rhinovirus, always seemed to come back positive with something on either the respiratory panel or the stool panel. They did a metabolic workup first, and that was all normal, but his growth was quite poor, and he just continued to have the same pattern of dehydration and acidosis. So he was put on amino acid-based formula. He was put on Elecare, and he had some improvement in weight gain initially, but continued to have this acidosis and was ultimately put on sodium citrate supplementation. It wasn't until someone recognized that he was having elevated white blood cell count, platelets, and sed rate that maybe this was outside of the typical metabolic condition, and started to think about, was there other underlying issues going on here with his GI tract. On physical exam, when we met him, we noticed first about coarse facial features. He had very woolly hair that was different than his mother's, and then had this really severe perianal rash. So he ultimately, due to the persistent recurrent presentation, had an EGD and a flex sig at about 5 months old, was noted to have scattered ulcers in the sigmoid, The antrum was significant for minimally active chronic inflammation, some mild eosinophilia. Sigmoid also had significant eosinophilia on the path, and apoptosis. And so he had whole exome sequencing that came back with compound heterozygous mutations in the SKIV2L gene. This is a diagnosis, a genetic diagnosis for trichohepatoenteric syndrome, or THES. It's known to cause intractable diarrhea, failure to thrive, facial dysmorphism, and hair abnormalities. And the thought, and there's several associated clinical features, including IUGR, liver disease, cardiac disease, platelet abnormalities, and immune dysregulation. I think the key thing about this is that there's both immune and epithelial components to this. So the epithelial, the clue here about the hair and or fingernails in some cases really helps you hone in on the thought about an epithelial process going on. Of course, then you have some immune component and hyperinflammatory component that led to the high inflammatory markers. So his current therapy at 3 years old is a JAK inhibitor. He has had recurrent admissions still for infections with dehydration electrolyte derangements. It's been challenging to manage him, largely because I think of the epithelial defect in the GI tract, and there isn't really many therapies that can target that at this time. And that's not something that would be amenable to a stem cell transplant because it's not a pure immune system problem. But thus far, we've been able to improve his inflammatory burden and see some improvement in his colitis and colonic ulcers with the JAK inhibitor. We have since that time identified 5 patients, including 2 siblings, all of who have SKIV2L or TTC37, which is another gene that causes THES. There's a wide range of symptoms and exam findings, as well as different degrees of immune dysfunction amongst these patients. And this is true amongst other published cohorts of THES. And it probably demonstrates the difference in penetrance of these genes. All of these patients, interestingly, had very similar intestinal inflammation with panel metaplasia and eosinophilic infiltrate seen on their biopsies. So there definitely are some similarities, while the other features can be quite a wide variety. So the goal of the very early onset IBD evaluation is to make sure that you're first looking out for monogenic disease. And a lot of times this can really stand out from the past medical history, the family history, the growth, and the rest of the child's exam. It's then important that we look out for who is going to benefit from us finding a targeted therapy. So can we identify monogenic diseases that then would do best with a specific therapy that is targeted just at that condition? And then are there other phenotypes that look like known monogenic diseases that are very similar that might benefit from a similar type of therapeutic approach? And then finally, we want to make sure that we think about those people who could have a non-GI complication. So what conditions could potentially evolve to HLH or hematophagocystic lymphohistiocytosis? So that would be like XIAP. That is immune deficiency that is higher risk for HLH. Or are there conditions that might be at risk for malignancy, like IL-10 receptor deficiencies? Those children are at risk for B-cell lymphoma. So important that we identify those people, both to make their treatment, to intervene with a treatment, but also to prevent these life-altering risky conditions. And finally, of course, we want to find any major immune deficiencies that may be at risk for sepsis pictures as well. So the NASPGHAN IBD committee had a subgroup come together to put together a position paper on the evaluation and management of very early onset IBD. And this provides a comprehensive overview of the workup, of the immune evaluation, as well as what exam findings and other findings to think about when examining patients and having a high level of suspicion for this condition. There's also been, from the NEOPICS group, an algorithm suggested for the workup of very early onset IBD that was published in 2019 in the IBD journal. It really helps to point out, again, these same features of when to trust your history and physical, when to move forward with the scope, when to do immune testing, what immune testing to do, and when to sort of take that next step into doing further genetic testing as possible. So the goals of these guidelines are really to help identify when certain levels of the test and the evaluation can help stand out certain types of monogenic defects or conditions that look like monogenic defects. So hyperinflammatory states can really be identified from the history, from the scope, from the labs, which could include really high inflammatory markers early on. Immunoglobulins, vaccine titers, and lymphocyte subsets are done as sort of the first pass of immune testing to look for things that might result in CVID or specific antibody deficiency, or other combined B and T defects. A DHR, of course, to use to rule out chronic granulomatous disease. And then a cytokine panel, sort of getting more specific on a screen from there to identify other types of immune dysregulation that may be missed in sort of the overhaul if you have a really high level of suspicion for a condition like that. We at CHOP have established a joint very early onset IBD clinic. It's a monthly clinic where GI, immunology, and nutrition all see the patient and family, and then sort of convene in real time about what labs need to be done and what therapy options really exist. From here, we've been able to grow our research program and do whole exome and whole genome sequencing to expand the genes that have been identified to cause monogenic IBD. And also then to identify those patients that are going to benefit the most from targeted therapies and ultimately the ones who might benefit from a stem cell transplant. So moving in conclusion, I wanted to just point out that there are certain red flags for monogenic disease that really should be focused on in the evaluation of a new patient where VEO-IBD might come into play. Thinking about the age of onset, knowing that monogenic disease is more likely to be seen in those children who've been struggling with symptoms since shortly after birth or within the first year of life. Asking questions about consanguinity, of course, raises suspicion for monogenic or genetic diseases. Understanding the history of infections in the child or any history of additional autoimmunity or polyautoimmunity amongst family members, as well as from the child in the family, understanding recurrent infections or conditions that have been overlooked, family history of HLH, and then thinking about, particularly for male patients, thinking about their mother's medical history and potential X-linked disease in the child. Panenteric disease, children who have inflammation in all parts of their GI tract, poor growth, these atypical findings in the pathology that I reviewed earlier that, alone may be confusing as to how these could be thought of as IBD, but together with the rest of the picture really need to increase your suspicion for VEO-IBD. And then an abnormal DHR oxidative burst should also increase your concern for CGD. There are many therapeutic considerations. We use the pathology as well as the immunology evaluation to help us decide when the right drugs could go with different patients, since we want to improve our personalized medicine and we want to use the tools that we do have right now. What can we take from the pathology? What can we take away from the evaluation to really help guide and choose the right drug for the right patient? Since we know that not all patients are going to respond to the medication as robustly as older children, can we improve the odds of that happening if we match the right child with the right drug? So patients who have very strong neutrophilic infiltrates, anti-TNF and anti-IL-1 medications can be very effective there. Patients with lymphocytic predominance or other concerns for regulatory or adaptive immunity defects may benefit from an immunomodulator like sirolimus or tacrolimus. Abatacept is particularly used for patients with LRBA or CTLA-4 deficiency. And then vedolizumab can also be quite effective in patients who have a predominant lymphocytic infiltrate. B-cell defects, of course, if you result in hypogammaglobulinemia, could benefit from IVIG. We've also used rituximab in some rare situations. And then a common phenotype that we have identified that benefits these hyper-inflammatory, autoinflammatory, very high inflammatory markers, fevers, mouth ulcers, lots of extraintestinal conditions may benefit more from a JAK inhibitor. And there are now multiple JAK inhibitors on the market that really have expanded our ability to better treat these patients. So our goal at CHOP, and I think all of the the teams that study VEO-IBD and care for these children are really that we know this group of patients is really cannot be lumped together as one group. And to choose the best medication for them, we really need to start to sort them into who would do best by which medication. And the more phenotypic information we get and immunophenotypic information we can add on top of what we see in the office, the more we can then parse them into different groups in order to really get the patients to get the most benefit, to decide who would not get benefit from a drug, and to spare those who might have an adverse event from a certain medication, and to make sure that we're not giving them a medicine that they should not have. So in conclusion, very early onset IBD is a rare disease with individual drivers, phenotypes, and different therapeutic needs than older onset IBD. There is both whole exome and genome sequencing available now, becoming more part of the clinical acumen, but also they're just very effective tools to identify new genes that cause VEO-IBD. It is really important to partner with other providers for a multidisciplinary approach, and to rely on your rheumatology and immunology colleagues in order to evaluate and treat these patients effectively. And identifying drivers or defects and targeting therapies can improve their outcomes, especially in these otherwise refractory cases. I have a very supportive team of physicians, physician scientists, nurses, nurse practitioners, and a research team that have helped us to grow our program over the years. And I just want to thank them and thank all of you at LASPGHAN and NASPGHAN for inviting me to speak about VEO-IBD today. Thank you.
Thank you, Maire. Excellent talk. It's a very important theme that we are seeing every time more cases that really very challenged patients. All these patients are very challenged to really understand what's going on. And thank you very much for your very important and very clear presentation. We are open for questions.
I think there's a question from Dr. Jose Cadena. He asked, do all patients with VEO-IBD should be evaluated with genetic testing?
Yeah, I think that's a great question. We, of course, have the luxury of doing, when we can't get genetic testing covered by an insurance, to do it by a research protocol. But we understand that that's not always real world. And there are, in the United States, some commercial labs that have made some genetic testing much more available at a lower cost. I think, you know, it really depends on the index of suspicion. I do think that if you have an immunologist to partner with and a way to do an immunology evaluation so that you're, you know, looking into sort of the most common associated conditions, chronic granulomatous disease, common variable immune deficiency, things like that, then you're likely to pick these things up clinically. And then in the cases of patients who are more refractory or from the get-go fall into the category of severe, you know, significant bloody diarrhea, significant severe anemia, and are just quite ill from the get-go and are going to be sort of a harder, you know, you already know that there's probably uphill battles for treatment with those patients. Those would also be ones that I would, you know, be trying to work towards getting genetic testing earlier rather than later, because there's always that question that comes up if they don't pass first-line therapy. Is there anything about the genetics that could clue us in to what might be the most appropriate second-line therapy? Or is there a reason why they didn't respond because maybe their disease is actually, you know, mimicking some other underlying genetic condition? So my short answer is, if it was a possible and perfect world, yes. But I think otherwise it should really be on patients that either don't fit the mold, are not responding to therapy in a timely manner, or from the very beginning just have a lot of significant concerns for severe disease. The one age group that I would definitely do genetic testing on would be the infants. So anyone with onset in the first year of life, I think, is an important group to look for, because that's the most likely group that you'll get a hit in.
We have here a question about the experience with ustekinumab.
Yes, we have used ustekinumab, I think, in some of similar situations as we do in regular pediatric IBD, patients who have intolerance or side effects from the TNFs that prevent them from having other TNFs. That is definitely some situation where we use ustekinumab. I think it's often quite difficult to obtain in the United States for the very young kids. We get a lot of pushback about that. I think our biggest concern about it is often the dosing. And that is, something I mentioned during the talk, is just that the dosing for these young children probably should be different. And doing that, of course, with ustekinumab is just harder to sort of figure that out. There was a clinical trial from Janssen about ustekinumab by Joel Roche and the Janssen group that did show that the higher doses for the lower weight kids is for the IV, 9 milligrams per kilogram, is probably more effective at getting them under control earlier. So there is some ability there. But I mean, we like it, I think, based mostly with the safety profile. And then, most times we are just trying to figure out the right dosing for them in the long term.
There is a question from Dr. Alicia. She's asking about the interpretation of fecal calprotectin concentration in healthy infants.
Yeah. It does add an extra layer of complication to figuring out how to interpret a calprotectin. And I think in the youngest children, I often find myself just needing more than one to reassure myself one way or another if this is better or worse and get a trend. I think calprotectin, while we love it and we use the trend, if you take a sample from a different time of the day, at different, two samples from one patient from the same stool can give you a different answer at times too. So it's not a perfect test. I think in a normal, healthy infant, we know that there can be a higher calprotectin than in older children. But I think it's all in the context of what's happening with the baby. Is the baby thriving, eating, hitting developmental milestones? Is there a lot of diarrhea? Is there blood in the stool? I think those are the things that you add that with the calprotectin to raise your suspicion.
To follow up on that questions, would you consider doing fecal calprotectin intervally to monitor disease progressions or?
Yeah, absolutely. I mean, I think, again, like trying to figure what the trend is and putting it into the context of the whole picture, but using calprotectin regularly to sort of get a sense of what their baseline is and when it adds up to the whole, what's happening with the entire child. But, I think we find that there's such a variety of presentations, and I think, not unsimilar to Crohn's disease or ulcerative colitis or pediatric colonic Crohn's, where there can be so much variation to the presentation and how that influences the calprotectin.
Another interesting question from Dr. Jose Cadena. Could cold milk allergies be a risk factor for developing VOIBD?
Yes, I really think that it's either that we are missing it and it's actually initially a presentation of VEO very young, but there definitely are some children who have all kinds of atopy who had cow's milk protein allergy from the beginning. We had looked with our allergy colleagues at some point, and of our population, it was something like 75% to 85% of the patients had that diagnosis. Now, I think in retrospect, it's always hard to figure out, was it a true concern for milk protein allergy? Was there a temporal relation? Did it respond to elemental formulas? But I think that's why they put into the algorithm that was published a few years ago in IBD, the idea of if you meet an infant who really is in the appropriate age range, I think that really has to be in those first early months of life, to give them the 2-week trial on elemental formula and really try to take that out of the equation, because you're really unlikely to be missing that. And if they persist through that to have poor weight gain or labs, then you progress towards colonoscopy. We really have thought that if you see something visual on colonoscopy, that is unlikely to be a milk protein allergy. But I really think that, their allergy is part of immune dysregulation. And that really might be a setup for why some of the part of the difference in the environmental factors that lead to more milk protein allergy may also be part of the reason we see more VEO IBD. I see a question about smallest patient. We have had patients transferred to us who were quite sick, in the NICU from day of life 1. We have one of our first successes with using a JAK inhibitor. It was actually in a child who presented with bloody diarrhea and progressed towards HLH and never had a genetic diagnosis made, but had significant colitis on colonoscopy, which was more like a flexible sigmoidoscopy. But that patient ultimately was put on a JAK inhibitor because of such overlap of the HLH and thrived from that. And that actually usually do include that case in our slide deck. But there are definitely patients in the first few months of life that we have used both standard conventional biologic therapy as well as small molecules. It really ranges, but some of the quite young ones are quite sick and have very prolonged hospitalizations in that first year of life.
May I ask you, Mary, regarding the use of immunosuppression like azathioprine, or you told us a lot about this, the infliximab, but tell us how much you use the immunosuppression. I'm asking you because we've been using more immunosuppression for these small babies than infliximab.
Yeah. You mean more like immunomodulators or like oral immunomodulators? We do use occasionally tacrolimus and sirolimus, but in general, our practice has moved away from using a lot of azathioprine. I think our concern in the youngest kids is, one, are we sure that this is not a monogenic disease that has a risk factor for lymphoma? So that would be, like IL-10 and other some of the other T cell regulatory pathway defects. That is one thing that comes into play. I think the other parts is that we didn't get as much traction with treating them with those things for the long term in terms of maintenance. But we have had more success with tacrolimus. We have used JAK inhibitors, both tofacitinib, upadacitinib now, but that it has to be swallowed in a pill form. So we've actually used ruxolitinib, which is a JAK1/2, which is similar to UPA, but can be compounded into a liquid. But honestly, we don't use a lot of azathioprine. And I think that is an area that is still, needs some more area investigation because it is the most commonly used. We use a lot of EEN. I do try to control patients a lot, and as some toddlers continue to stay on EEN, both from a nutritional standpoint as well as a therapeutic standpoint, that's been successful. But yeah, I think the azathioprine is just very hard to sort of balance the risks with the benefits of the immunosuppression.
Maybe the last question. So given a high rate of biologic or anti-TNF in VOIBD, when would you consider switching to another therapy, or when would you switch? Would you switch to other biologic or just switch to tacrolimus?
Yeah, I think it depends on the situation. A lot of, we see patients who do react, like if their dosing is not effective, and that can be hard to know if they need how high a dose is. We've had patients that need 10, 15 per kilo to get just to have circulating level, and not necessarily. And then there's also patients who at this very young age get that much medication and can't be spaced past 2 or 3 weeks, which is not a sustainable plan. So in those cases, if there's subtherapeutic levels, if they are having, or if they have excellent levels, but they're still having, severe inflammation, elevated inflammatory markers, anemia, then we usually start to think about other therapies. We have also, when possible and patients are not quite severe, have started with Entyvio with vedolizumab as a first-line therapy. And I think there's some, more data now that there's been the Vito Kids study that came out that was multi-center and able to show that there is some safety data there. And also, but that medication then helps you start them on, and maybe you can save the anti-TNF for a later point if they are sicker and when there's more option there. So that is one thing. I think, using your same measures of success as you do with a pediatric patient to decide when the patient's doing well or not, I think is an important thing, but also giving the medicines a chance, because the pharmacokinetics are different. And I think that's can't be understated. I really, wish we understood more about the pharmacokinetics of these medications in the young child, because I think it would save insurance companies time and our time and everybody's time if we were able to dose things appropriately and not feel like we're wasting their drug. So, similar, it really depends. I mean, with the classic patient of colitis and anemia, giving those drugs if with good levels, the 4 to 6 month window, as you would with other older patients, and then sort of deciding what is the distribution of the disease, are there extraintestinal manifestations, are there other considerations that would guide you to continue to use more systemic therapy, or could you have more targeted therapy and look at just Entyvio for colonic disease only and get enough treatment for them?
All right. If you don't have more questions, we thank you very much again for you bring us that so nice presentation. And Vo, would you like to say something?
Sure. So Dr. Conrad, on behalf of NASPGHAN and LASPGHAN, thank you very much for your experience and sharing with us your expertise in VOIBD and being with us in this interactive discussion. We thank the NASPGHAN and LASPGHAN leadership for supporting this webinar series. And to our audience, thank you for participating, and we hope to see you again in the next webinar next Thursday. Thank you, everyone.
Thank you very much.